Dr. Salim.
Computer audio. ഞാൻ ചെക്ക് ചെയ്യാവുന്നതാണ്.
കൃഷ്ണൻ മാസ്ക് ഒക്കെ ഇട്ടിട്ടിരിക്കുന്നത്. ഗുഡ് ഈവനിങ് കൃഷ്ണൻ. കൃഷ്ണൻ എന്താ മാസ്ക് ഇട്ടിരിക്കുന്നത് കൃഷ്ണൻ?
മാസ്ക് തൽക്കാലം. ഹലോ, കേൾക്കുന്നുണ്ടോ? മാസ്ക് ചിലപ്പോ ഇടക്കിടക്ക് ഇടും.
വീട്ടിലല്ലേ?
ആ, വീട്ടില് മാസ്ക്.
ഓക്കെ. ഗീത ഗുഡ് ഈവനിങ്.
ഗുഡ് ഈവനിങ്.
Hello.
Geeta, good evening.
Good evening. Good evening. You look fine.
Yeah.
Absolutely. Krishnan. Good
ആ
evening.
ഗുഡ് ഈവനിങ് ഗുഡ് ഈവനിങ് കേൾക്കുന്നുണ്ടല്ലേ?
കേൾക്കുന്നുണ്ട്.
ഓക്കെ ഓക്കെ. ഇത് ഈ സ്പീക്കറെ എങ്ങനെ പ്രൊനൗൺസ് ചെയ്യാം?
I don't know.
മാർക്കോ
Not sure. മാർക്കോ ഗാറ്റോർണോ എന്ന് പറഞ്ഞാൽ should be okay.
ഗറ്റോർണോ. ഓക്കെ ഓക്കെ, ശരി. ഞാൻ ഗട്ടോർണോ എന്ന് പറയാം.
അറിഞ്ഞൂടാ. I don't know.
ഓക്കെ ഓക്കെ.
Probably ഗാറ്റോർണോ.
ഇതിൽ നോട്ട്സ് മാത്രല്ലേ ഉള്ളൂ, അത് മാത്രല്ലേ പറയാം. അതേ ഉള്ളൂ കേട്ടോ. കുറച്ച് ആ ഒരു ബ്രീഫ് ഒരു പാരഗ്രാഫ് അതല്ലേ ഉള്ളൂ അല്ലേ?
That's okay.
Geeta, has he joined? Geeta?
No, I cannot see. I don't think so.
Director number.
ഇതാ ഈ കമ്പ്യൂട്ടറിന്റെ
Okay.
Shrama's computer. I don't know whether we can change the name. ചേഞ്ച് ചെയ്യാൻ പറ്റും തോന്നുന്നു. നോക്കട്ടെ. rename.
Just the previous slide. There was a this one. Okay, this one or the previous one also. Yeah. It was a comparison with the previous one. Yeah. It was the comparison of the oral rotavirus vaccine.
Oh, you. Oh. Oof.
Hello?
I think he has joined.
Hello?
Geeta, yeah.
Ajit, you can say.
Good evening, sir.
Hello, hello, hello.
Hello.
How are you?
I'm fine, sir. I'm Dr. Ajit, HOD Pediatrics.
Nice to meet you.
Yeah. Yes, Dr. Geeta is here. Geeta,
Yeah,
Geeta.
Professor Gatorno.
Hello.
Yeah, very nice to see you, sir.
My
Very
pleasure. My
excited to see
pleasure.
you.
Great pleasure.
Yeah.
screen share ചെയ്തിട്ട്
Yeah.
Ajay.
Can we try and see whether the slides work?
Yes.
Whether the slide share works?
Sure. Sure. Just a moment.
Yes, sir. You can do the slide share now.
Okay. Let's see. Share screen. Can you see?
Yeah.
Yes,
Yeah,
sir.
it's coming, sir.
Yeah, it's perfect.
Very good.
Yeah.
Okay.
Can you test the audio?
Audio, is it alright? Can you hear me in a good way?
Yeah.
Yeah.
Can we increase the volume a little bit, sir?
Now, is it okay?
Yeah.
Is it
Yeah.
better? It's
Yeah,
okay?
but it could be a little higher. Can we increase it a little more?
This is the maximum.
Okay, that's fine. That's fine.
Okay. Very good.
Yeah.
So just a question. So, I mean, the doctors that are here are expert in which kind of audience we have?
Yeah. So actually, we have mainly practicing pediatricians and pediatric postgraduate students and a few pediatric immunologists.
Okay.
Yeah. And this is actually conducted by the Indian Academy of Pediatrics at Calicut and the Government Medical College Kozhikode Department of Pediatrics, as well as we have the Institute of Genomics and Integrative Biology, Delhi, and also the Foundation for Primary Immune Deficiency Diseases.
Wow.
Yeah, we have amongst us a principal scientist from IGIB Delhi, Dr. Vinod. Dr. Vinod, are you there?
There is a green, no, a gray. However, yeah. So it's fantastic. Usually, I mean, this is a series of different different topics. I understood.
Yes, sir.
Okay, so there was already someone that had a sort of initial, let's say, overview on what autoinflammatory disease are, because I focus just on cryoperinopathies in this my presentation. I didn't know if I had to struggle a little bit on a general concept of autoinflammation.
Yeah. This is the 6th in the series.
Okay, so someone else had already, let's say, said what is an autoinflammatory disease and so on. So I can go directly to cryoperinopathies. Gita, you are blocked, I'm afraid. You are freezing.
We have a small
which layer of the atmosphere is rich.
Can we start, Geeta? Ajay?
Yes, sir. I think everyone has come. Shall we start, madam?
8 മണിയാവണ്ടേ?
5 more minutes, sir.
Welcome കഴിഞ്ഞ് വരുമ്പോൾ 8 മണിയാവും സർ.
തുടങ്ങി.
ഇൻട്രൊഡക്ഷൻ
Sir, shall I start now? Mohandas sir will be late, I think.
Okay, you can start, Ajay.
Good evening, everyone. So today is the last session of our pediatric immunology series. That is, we have a 5 series done so far, excellently coordinated by Dr. Geeta. So this is the last one in the series, and it's a privilege to have Dr. Marco Gaetano for giving, who is an expert in systemic autoinflammatory diseases, for giving us an update on this cryopyrinopathies. So firstly, I would like to welcome Dr. Marco Gaetano for the pediatric immunology seminars. We have Dr. Ajit Kumar. Sir is the professor and head of Department of Pediatrics. Welcome, sir. We have Dr. Vinod Skaria. Sir is the director in IGIB. I also welcome, sir. And we have Dr. Geeta, who is running the Pediatric Immunology Department in Government Medical College, Kozhikode. Welcome, ma'am. And we have a lot of senior faculty, senior professors of Calicut Medical College, Shashidan sir, and our IAP president Mohandas sir, who will be joining soon. I welcome everyone, and I hand over to Dr. Ajit Kumar sir for his presidential address.
Thank you, Ajay, and good evening, everyone, and good evening, my teachers and dear friends. It's a last of the series on autoinflammatory syndromes and primary immunodeficiencies, and it was really interesting series for all of us, and also we gained a lot of knowledge in this during this period, and also got to know a lot of scientists who were working in this field. So on behalf of Department of Pediatrics and Indian Academy of Pediatrics, Indian Academy of Pediatrics Calicut branch, and CSR IJB, Guardian Consortium, and FPID, I'm really take this opportunity to welcome our dear speaker, Dr. Marco Gaetano, and who is from the Gazzellini Institute and of Italy, one of the premier institutes and in Italy. And I also welcome all our teachers here, dear teachers, as well as all the delegates who are attending from all over the world. And also welcome our faculty in the department, as well as senior pediatricians to this. I also welcome all the IAP office bearers, Indian Academy of Pediatrics office bearers. And as you all know, NLP3 is a spectrum of autoinflammatory syndromes. It's very rare, and we have CAPS, Muckle-Wells, NOMID. So these are very rare syndromes which if we identify, have a good treatment response, and which may present even from the newborn period itself. So very important to identify them, and even though they are very rare, the CAPS, the Muckle-Wells, the NOMID. And so I think we have the best speaker for this, and I invite Dr. Krishnan to introduce the speaker. Dr. Krishnan?
Okay, am I audible?
Yeah.
Okay. Good evening, all. It's my privilege to introduce today's speaker in front of you. Today's speaker is Dr. Marco Gaetano, who is basically a researcher with a keen interest in the field of autoinflammatory diseases. Dr. Marco Gaetano is the head of the unit for autoinflammatory diseases and immunodeficiencies at Giannina Gazzellini Institute in Genova, Italy. He is the president of International Society of Systemic Autoinflammatory Diseases. He has a high H index with more than 250 publications in international journals and more than 16,000 citations. He is the editor of a reference book on familial Mediterranean fever. Dr. Marco Gaetano currently is the principal investigator of many research projects. Among these, E-rare and the Euro fever are the main research projects going on. With these brief words on our speaker, Dr. Gaetano, I hand over the mic to our IAP President, Dr. Mohan Das, for continuing the session. Thank you all.
I think we want to directly go to Dr. Mondas is there?
No, sir. Mohandas sir is not there. We'll directly go to session, sir.
Yeah,
So, I invite our beloved speaker, Dr. Marco Gaetano, to deliver today's speech. Welcome you, sir.
Okay. Can I start?
Yes. Please,
okay.
Sir.
Thank you very much for your kind invitation. It's a great pleasure to talk with you all. I'm very, very happy. Unfortunately, I would love to come to visit you as soon as possible when this nightmare of the pandemic will end. This is my town, Genoa, and my hospital is on the seaside. If you want to come to find me, you will be, of course, more than welcome. Today I am asked to talk about a very, very favorite topic to me, that is the cryopyrinopathies. Now we should say NLRP3 mediated autoinflammatory disease with the new nomenclature. I hope that, okay. For us as pediatrician, the story starts from 1981, because when Anne-Marie Prieur in Necker described for the first time patient with a permanent skin rash since birth with fever, arthritis, abnormal epiphyseal appearance, neurologic involvement with mental retardation, and chronic meningitis. And she called this disease as CINCA, chronic infantile neurological cutaneous articular syndrome. This is the starting point from a pediatrician related to this condition, but 20 years before, two dermatologists, Mackel and Wells, identify a new condition, genetic condition, clearly autosomical dominant, in which the patient have urticarial, deafness, and amyloidosis, and that is what is now known as Mackel-Wells diseases. Another important aspect that came 20 years, and that is the typical feature of Mackel-Wells syndrome with urticaria rash, hearing loss, arthritis, and a possible development of amyloidosis. But 20 years before, in 1940, we have the first identification of patients with the so-called familiar urticaria, familiar cold urticaria, in which the patient have recurrent episode of fever with urticaria rash, conjunctivitis, arthritis after cold exposure. So again, in an autosomical dominant fashion. This helped our friend Al Hoffman in 2020 to identify in some cases with a story of Mackel-Wells, a family history of Mackel-Wells or FCAS, the gene, using the classical approach at that time of gene hunting, that came out for the identification of the gene that was called at the beginning CHAS1, cold induced autoinflammatory syndrome 1, but is now known as NLRP3. We are in debt with this man that unfortunately slept away some years ago. Jürg Chopp is a Swiss biochemistry that in the beginning of the 2000s, he was able to identify the role of NLRP3 in the formation of the so-called inflammasome and the activation of IL-1. As you know, before the identification of the inflammasome, what we knew is that IL-1 is produced as a pro-cytokine after stimulation of, for example, toll-like receptors. There is a huge amount of pro-IL-1. You can see here this huge amount of the protein that have to be cleaved by an enzyme that is called caspase-1. Thanks to the knowledge of the NLRP3 and his, let's say, binding with other proteins such as ASC, we were able to identify, Jürgen Chopp was identify this system that is called inflammasome, that is able to activate the caspase-1 for the cleavage of IL-1 and the secretion into circulation. This is now known like NLRP3 inflammasome. Of course, there are other mechanisms that can control the activation of the inflammasome, ATP, reactive oxygen species, and different signals that are able to activate the system in a very potent way. We also interact with Charles Dinarello, that was the founder, the person that in the 1970s was able to identify this cytokine, the first cytokine, that, as you know, has many potent inflammatory phenotypes. As you know, the patient with NLRP3 have a gain of function mutation that lead this patient very active in the overactivation of IL-1 and over-secretion of IL-1 upon very little stimuli. That means that this patient produces huge amount of cytokines. That leads to a very severe phenotype in patients with the most severe phenotype that has been observed by Anne-Marie Prieur in Necker with a very early onset, you can see here. With the skin rash that is rather typical, is very difficult, is urticarial, but is very difficult different from a classical urticaria because is mainly related, is not itching, is not related to angioedema, it not respond to antihistaminics, and of course it can vary during the times. So, for example, you can have it in the arms in the morning. Maybe it could disappear and appear in the trunk, so it can vary during the time, but not as quickly as in the normal urticaria. And most importantly, if we make the biopsy with in this condition, we cannot find any sign of urticaria. We found a very important perivascular infiltrate with a lot of neutrophils, no sign of vasculitis, not fibrotic necrosis and so on. This is rather typical for neutrophilic dermatosis. So these patients have this urticaria rash with inflammation that is very relevant, and that have to let's say make us aware on the possibility of this condition. Another important task for the most important the most severe manifestation that is SINCA is this skull abnormalities. You can see some of our patients with different mutation, and they really seems to be the same with this frontal bossing. This adolescent was able to hide with the hair, but this is rather consistent in many of the patients. Other possible involvement is a bone involvement. They can have an overgrowth on, for example, patella or other bones. You can see here these signs that is not related to a pulmonary involvement in a patient with a mosaicism, and again also at the level of the thumb. This is rather consistent with the more severe phenotype, SINCA phenotype. And there was some doctors, some colleagues that were able to identify and to study, and they find that there is in this patient endochondral ossification with alteration of the chondrocyte. This is rather characteristic, and NLRP3 is expressed mainly in monocytes and the myeloid lineage, but also expressed in chondrocyte. We still don't know which is the function of an NLRP3. And what is possible to see in some patients is the possibility to develop chondroma, and in some unfortunate case also even chondrosarcoma.
Dr. Ajay?
Dr. Marco, are you there? I think we have lost.
Yeah, I think so. Let's see.
Ajay?
Hello?
Yeah.
Yeah.
Yes,
Sorry.
sir.
Is it okay?
Yeah, can you start sharing
Yes.
screen once more?
Okay. Did I interrupt here in this slide or before?
Just before. Yeah.
Before?
Yeah.
When?
Can you
Hello?
can you start sharing your screen? It's
Yes, but when until what were you able to listen
Up to the slide on chondrosarcoma.
Chondrosarcoma, yeah.
Chondrosarcoma, very good.
Sir, you have to stop screen now and do it again.
Okay, I share the screen again. Can you see?
Yes, sir.
Okay, very good. I start again. I continue. So what I was saying that beside this, many of these patients have a growth delay related to the genetic diagnosis, but also the persistent inflammation. I was just showing to you the difference in these two twins, dizygotic twins. You can see here this patient on the right, the mutation, and the twin sister that is completely healthy, the difference. The neurological involvement in the more severe part, the SINCA, is so relevant as in the first presentation, these patients have a chronic meningitis with headache. They can have early morning vomiting. There is the classical leptomeningitis, increased intracranial pressure. And of course, one possible complication is brain atrophy and arachnoid adhesions that can lead, of course, to a severe damage with mental retardation. Before the initiation of proper treatment of this patient, most of them had a very, very important mental retardation. That is very, very important. Yeah. That's why it's so important to recognize early this condition, because we have to make a very early diagnosis and very early treatment to try to prevent the neurological manifestation and the progression of the brain damage and mental retardation. I will show you an example. Also, hearing loss, as you know, in CAPS is very important. This patient can develop very early. You can see one of our patients, hearing loss, severe hearing loss, that can be mild or moderate, but in some patients very severe. 60% in our Italian population were affected by this kind of diseases, this kind of complication, and this is related to enhancement contrast, enhancement inflammation of the cochlea that can be observed with specific, let's say, the specific magnetic resonance images to be detected. It's very important to study. Michael Wells also can have a hearing loss, but we will talk about later on. A manifestation, they can have conjunctivitis, uveitis, the corneal infiltrates, and what is quite important is papilledema. It's very important to follow this patient for the ocular examination, eye examination. This is a papilledema of a patient with this variant. Of course, they can have some very important complication like corneal clouding, retinal scarring, and very, very important optic nerve atrophy that can lead to blindness. That is another reason why you have really to follow very, very closely the patient and also to try to recognize very early the disease, because otherwise the complication could be permanent before any treatment. We use a lot of optical coherence tomography, OCT, to follow this patient. You can see here how it can be really useful to make understand the papillary edema that you can see here in this patient, and also a reduction of optic nerve thickness in this other patient. So it's a examination that we perform every 6 months. What is quite interesting that, of course, you have seen the most severe phenotype, and you have to be very careful in recognize this phenotype with the early onset urticaria rash and inflammation, and with this severe neurological involvement. But however, you have to understand that you can follow also patient like Nicolas that was born in 2013. He had, from the first week of life, sporadic urticaria rash. After 2 weeks, a daily urticaria rash with no fever, normal mental neurological development. It's very beautiful, very tiny little kid, no dysmorphism at all. At the age of 9 months, he went to an allergist evaluation. He had some examination, even antinuclear antibodies and complement that were normal and negative, but as usual, the allergologist sometimes forget the existence of acute phase reactant. They didn't check for ECR or CRP, and indeed they were elevated. That would be something that could be alert this patient. And so in the first visit in our hospital, he was a normal neurological development. He was a very tiny boy with this skin rash, no facial dysmorphism, no neurological impairment. He had just a mild skin rash. CRP was elevated. Of course, the diagnosis was very suspected with a milder form, much milder rather than in Synca. But what was quite interesting in this patient was to talk with the family. And indeed, we discovered that the father, that at that time was 34 years old, at the age of 2, started to have an urticaria rash with fever, arthralgia, arthritis, conjunctivitis. At the age of 25, he detected a severe bilateral hearing loss, a late onset hearing loss. Then, finally, at the age of 29, a diagnosis of Still disease was pointed out. And so, finally, a treatment with anti-IL-1 blockers was started with a complete control of the clinical laboratory manifestation. She was cured. And so they were so happy. And of course, that was cured like Still disease with anti-IL-1 blockers. So what the sad part of the story that this man waited for several times before having a child because he was worrying to have a genetic disease. And all adult rheumatologists say, no problem. Still disease is not a genetic disease. Go ahead, no problem. And it was very hard to tell them that indeed he was maybe affected by a genetic disease. And indeed that was the case in the father and the son that were carrier of this variant that is linked with a less severe form of cryopyrinate, that is Muckle-Wells syndrome, in which, as you understood, the phenotype is much less severe. And in contrast with the Synca, in which that is so severe that you usually have a de novo mutation, so you do not have other members in the family. In this condition, milder, you have, of course, the classical autosomical dominant penetrance. Of course, the quality of life in Synca patient is very, very bad. You can see here the difference of a normal individual and in red, the Synca patient. Many aspects of the quality of life are really bad. And you have, of course, an intermediate alteration of quality of life in patients with a milder form, Muckle-Wells. But you can also meet patients like Emma. This is quite recent. Emma, 6 months, have again urticaria rash, have a limb with increased CRP, anti-nuclear antibodies, and a good response to steroids, some fever at a certain point. The interesting thing is that also the father have urticaria rash, arthritis since childhood with keratuveitis, and it was labeled as a seronegative arthritis and was treated without success with methotrexate and steroid. Also, the grandmother had the same presentation with no keratouveitis, but it was more labeled because of the urticaria rash and elevation acute phase reactant as a lupus-like phenotype, and she was treated with hydroxychloroquine with no response. The important things of this patient, and that was also the same for Emma, that both have a very mild form that was mainly observed during the winter season and after cold exposure. So usually they went quite well, but when they were exposed to the cold, of course, they have these bouts of the disease. The same clinical picture, very interesting, was also observed in the two other generations. So this is the first family in Italy, the big family in Italy that we have with a classical familiar cold autoinflammatory syndrome, in which the syndrome are mainly related to exposure to cold. It's the milder form of the cryoperinetis. You understand these conditions are three conditions that are related to the same spectrum, a similar variant, different variant of the same gene that can give rise to a different severity, from familiar cold autoinflammatory disease to the more severe SINC. Thanks to the Eurofever registry, we were able to study a lot, many patients. This is a patient study some years ago. Also, we try for the first time to have a sort of genotype-phenotype correlation, and you can find indeed the possibility, if you have a patient, for example, with this mutation, you can have let's say much less probability to have a positive family history or not to have a neurological involvement, or for example, if you have this kind of mutation, you have a lot of probability to have a chronic course and, for example, hearing loss. You can see here. So adding the number of patients, we can also understand more on the possibility of the different genotype to give different phenotypes. One important point that is pertinent to this condition is that a relevant number of patients that are clinically diagnosed as SINCA or NOMID show no heterozygous germline mutation for NLRP3. Especially when the Sanger method was observed, was rather possible that this patient with a clear-cut SINCA phenotype turned out to be negative. We have to say that most of these patients have a somatic mosaicism that was identified in more than 70% of these negative patients. You can see some somatic, some cells are carrying of this condition with a level of mosaicism that could be very low, from 4 to 35, but some patients can have a clear-cut and very severe phenotype, even with a very low percentage of cells leading with the gene. This possibility is also less frequently in patients with Makel-Wells patient. In our Italian population, we have 30% of our patients that was a mix between CAPS and Makel-Wells, in which we found patients with a mosaicism. We also have to know and also to tell to our friends, adult rheumatologists, that sometimes we can meet patients with a late onset CAPS phenotype. You can see this patient at the age of 54 start to have the classical phenotype of Makel-Wells just at the age of 54. We are used to think about these diseases in a very early onset, but some somatic mosaicisms can present with a late onset. So some help for the diagnosis and classification of this condition. So if we go to the literature, some 2 years ago, last year, we published this effort in the context of the Eurofever registry, and in which we try to set up the new classification criteria for autoinflammatory recurrent fever. That was a huge, let's say, effort, because we took 3 years evaluating through patient, making a analysis, statistical analysis with the help of the expert, and then making a consensus among the expert to build up this evidence-based criteria for the classification of the recurrent fever that for the first time are linked together the presence of genetics with the presence of the clinic. So for the first time, you have the possibility to recognize patients that have a confirmed NLRP3 genotype with urticaria rash, red eye, and neurosensorial renal loss. And even to label if the patient have not confirmatory variant of unknown significance, if they have at least 2 of these conditions in the presence of inflammation. These criteria have a very high sensitivity and specificity, as you can see here. Okay, another important tool that you can use if you have the possibility, of course, to make the genetic test is this classification. We did this kind of effort for the classification criteria thanks to a grant of the European Union with a ERAR project. In the same grant, there is now also a part related to the geneticists. They were able to make this effort to the classification of all the variants of the main autoinflammatory disease that are included in the InFever website. You know that the InFever website is a very important website in which you can find all the variants that has been described for the different and the main autoinflammatory diseases. And thanks to this project, we were able to provide a classification to each variant that is included in the registry. And you can see here, if you have a patient with this variant, you can go to the website and to see if this variant is considered pathogenetic or likely pathogenic or benign or uncertain significance. This is rather a good tool that you can use in your daily practice. And it's brand new. Another tool, if you go to the Eurofever website, what we did with, not me, but my resident did an incredible job to screen all the patients that were included in the registry and to describe all the phenotype associated to the phenotype, to the genotype. So, for example, for this variant, our residents were able to say how many patients we have in the registry, which was the age of onset, how many we have a continuous or recurrent disease course, and the main clinical manifestation, the less common manifestation, particularly the response to treatment, and also some particular complication. Again, if you found the patient with a mutation, you can go to the website and just to see what happened to the other patient with this variant. How to treat patients with fibrin-associated periodic syndrome? You know that the strategy was related to what we usually do in our immune system. As you know, we are able to provide a sort of moderator that is I1 receptor antagonist that is able to compete with the receptor at the level of receptor. So it's able to compete and bind just on the subunit of the receptor. And this is very important because it's block the receptor. I1 beta is not more able, and also I1 alpha are not able anymore to make a binding with the wall, let's say, receptor, and this do not transmit the signal because just one part of the receptor is included. So thanks to this, as you know, a recombinant I1 receptor antagonist was provided, and that was done mainly for rheumatoid arthritis and was a failure for rheumatoid arthritis, I have to say, but we were very lucky because as soon as we understood the genetic cause of CAPS and also the pathogenic mechanism, thanks to the Jürgen Choppe, the inflammasome. This is a fantastic example of translational medicine. So we understood that there was a treatment already available in the market, and our colleague in London, Phil Hawkins, Ellen Lachman, started to treat the first patient with IL-1 receptor antagonist anakinra. That was our first patient, that is a mosaicin, I have to say, that has a Synca phenotype. Since the first day of his life, he has urticaria rash, a headache, and other stuff. And fortunately, after the, the first injection, everything went away. You can see here, there was completely switch off. It was 33 years old at that time. And of course, his life changed completely. This is the treatment of choice. Of course, we have in the availability of other IL-1 blockers, especially in Europe and the United States, in other countries. I'm afraid not in India. Maybe we can discuss. We have also the monoclonal antibodies, canakinumab. I'm not sure that you have anakinra, and maybe we have to discuss. Of course, this leads to an incredible amelioration. You can see here before treatment, the quality of life, and what happens after treatment. Most of the patients have a complete amelioration, sometimes a sort of a normalization of the quality of life. These are the possible treatment. So there are again some open questions on treatment in terms of long-term efficacy, what to do in very young children, and so on. Even because when we have some data from the Eurofever Register, this is some years ago, many years ago, in 2013, what was quite interesting that there was still some patient, and a relevant number of patients, that of course have a complete efficacy of anakinra or canakinumab, but there are still some patients that have a partial response. This is rather important. So sometimes some patients have still some elevation of acute phase reactance, still some clinical manifestation. This is a problem, especially for the problem of some clinical aspect. It's clear that the treatment usually is able to completely control in most of the patients the clinical and laboratory parameters. So they are doing very well in terms of acute phase reactant, rash, arthralgia, and so on. What is quite interesting, even from the control of ocular manifestation, there is in some patients an amelioration of optic nerve thickness. What is the problem is that despite the treatment and despite the complete control of the acute phase reactants, there are some patients that still progress towards hearing loss. That is a possibility, and this is a main issue, one unsolved problem in this condition, because there are some patients that can improve the hearing loss, but some of the patients can progress towards hearing loss despite the proper treatment and complete control. So, of course, this is also related to the fact that if we make a needle aspiration of the cerebral liquid, we can find some parameters of inflammation. So the good practice is, especially in very severe syncopation, is sometimes to make, of course, a magnetic resonance, and sometimes also to check there is a complete control of CNS inflammation in this patient, because otherwise you have to increase the dose of the drug, even if the patient has a complete control of acute phase reactants. And there are some experience on, for example, some years ago at the care in Paris, in which it was clear that in some very severe and bad CAPS patient, Synca patient, you have to increase the dose a lot to have a complete control. You can, of course, control the growth, the overweight, but sometimes you have to reach dosage of 7, and some patients we arrive also to something like 10 milligram per kilo, considering that the starting dose is 1-2 milligram per kilo. So you have to increase in the very severe patient a lot the dose to control the overactivation of IL-1. Indeed, this treatment is with anakinra is rather safe. This is the experience in the NIH cohort that show that the number of the adverse events are not that high, and most importantly, prevalently, they are mild or moderate. You can see here, very few patients have a severe adverse event. So this treatment seems to be very safe. This is the same also, I have to say, for canakinumab. You can have some injection site reaction, but that in this condition is less frequent rather than in other conditions. They usually do not have. They can have at the beginning of the treatment, but you can see here afterwards they tend to handle very well with the site reaction with anakinra. What to do in very young children? This is a tricky condition. Of course, if you have the possibility to have anakinra, you have to start very quickly. I have to show you the experience of Anna. You can see was very bad, very severe, a classical Sinca phenotype with the bossing of the head. You can see the neurological involvement. I was very worried because she was the dizygotic twin that I showed you before, and the disease onset was very early. Daily urticaria rash with a low-grade fever, acute elevation, acute phase reactant. We make the clinical diagnosis at the age of 5 months. He had this stunted growth, but we start anakinra immediately. That was very important, of course, even before the result of genetic test. She had this important neurological involvement. And of course, before the advent of an early diagnosis and early treatment, for sure, Anna should have a lot of neurological impairment. That was not the case because we were able to increase the dose. She had a very good control of acute phase reactant, but unfortunately, with slight elevation acute phase reactant, we have to increase the dose, even giving the dose splitting in two. We arrived to 7 milligram per kilo, splitting every 12 hours, and split in 2 doses to control. I have to say that fortunately, Anna had a complete normal neurological development. She's intelligent. She go to school at the same intelligence of the twin sister. Unfortunately, she progressed toward hearing loss, I have to say, but she's normal, and she is Anna. This is the card from the family some years ago, just to show the good story of Anna with her sister. The canakinumab also, you have to increase the dose. There is this study some years ago, a trial that showed that pediatric patient with, especially with NOMID, need to have a higher doses rather than patient with Makel Wells that can have 150 milligram every 8 weeks. That is not the case for the pediatric patient that have to increase a lot the dose. In a very small study, but in daily life, we are able to observe 1 year of treatment in CAS patient, and we understood that if the patient with Makel Wells can stay very well with 100 milligram or 2 milligram per kilo every 8 weeks, the patient with Sinca have to increase a lot the dose. You can see here, every arrow is an increasing of the dose to keep the good control, and most of the patients need 4 milligram per kilo or 300 milligram every 4 weeks. So again, you have to increase the dose according to the severity of the diseases. Okay, so alternative drugs, this is quite interesting because I understand that anakinra is daily injection. Canakinumab is very expensive, very difficult to obtain. It will be important to have other I1 blockers or drug that can be used. There are some small molecules that are under development, and even some in which there are some clinical trials ongoing. For example, this one that is an inhibitor of NLRP3 inflammasome. The other, OLT 177, we were included in this paper, and we provide evidence that these inhibitors were able to reduce the I1 secretion in our patient. in vitro. We also provide in our lab a mouse model of cryoperiodopathy. That is a very interesting mouse model in which the mice, as you understand here, have a much less survival here. But what is interesting, because there are several mouse models that usually die very early in the first week of the disease. This model is much milder. You can see here they can have several weeks of life, and that they allow them to develop a chronic disease very similar to the human disease, in which they also can develop systemic amyloidosis deposition. And we were able to make a study on the use of esomeprazole. High dose of esomeprazole was able to reduce a lot the survival, to increase the survival of the mice treated, and reduce the secretion of pro-inflammatory cytokine and prevent the deposition of amyloid. We think that the proton pump inhibitors are inhibiting this important pathway for the calcium efflux that is important for the activation of the second signals. As you can see here from this cartoon, there are many different strategies to block the IL-1 oversecretion, not only anti-IL-1 or IL-1 receptor antagonists, but also antioxidant, because reactive oxygen species are very important for the activation of inflammasome, some inhibitors. And recently there is also an important paper using some drugs that are, let's say, controlling the formation of the pore of Gas-Dirmin that is very important for the pyroptosis. This group was able to identify a drug that is used usually for the alcoholic, for the people that is addicted to alcohol, that is dulciferin, that is very able to prevent the formation of the pore, of the Gas-Dirmin formation, pore formation, and has been also observed to reduce significantly mortality in IL-1 mediated mortality in model of sepsis. So there is still a lot of things to do in CAPS. It's a fascinating disease that in a way was a prototype of an autoinflammatory disease. You know very well that knowing the mechanism of activation of the inflammasome, we understood a lot of mechanisms related to inflammation in different multifactorial and very frequent diseases like gout, even like in different vascular manifestation in heart attack, and also even in tumors. And this was related to the study of this system. There is still a lot of things to do for the patient. This is the people leading, working with me in the Gaslini Hospital, all the Center for Autoinflammatory Diseases and Immunodeficiency, with the people in the lab and the clinicians, the Eurofever project with the staff of Printo, Nicola Ruperto, and all the people included, the patient in the Eurofever project that is more than 4,000 patients with different diseases. I invite you to contact me if you want to be part of this huge international project that we have patients from India, and we would love to collaborate, of course. I finished with this presentation of the Congress of our society, International Society of Autoinflammatory Disease. I have an honor to be president, and next year we will not have, unfortunately, the meeting in person, but it will be possible to follow an interesting new way to have a meeting. It will be not in 2 or 3 days like for other meetings, ACR, EULAR, press and EULAR and so on. We decide to have a periodic congress. Of course, dealing with a periodic fever, we didn't have any choice other than make a periodic congress. That means that we will have a congress that will last for 6 months. Every month we will have 2 sessions, so everyone can connect it. and follow the section, not in 3 days, but during the year. I hope that it will help you to enter again in contact with the world, the fascinating world of autoinflammatory disease, that you can facilitate you to participate in the community of International Society of Autoinflammatory Disease that is very active and work very well. So thank you very much for your kind attention. Of course, I'm very happy to take your question whenever you want.
Sir, there are few questions in the chat box. One is regarding NOMID. Do these children always present at birth? And if not, how long can the presentation can be delayed?
So thank you for the question. Of course, the more severe NOMID patient really started in the first day of life. So if you have a patient with this typical urticarial rash with elevation acute phase reactant, of course you have to think among the different differential diagnoses immediately to this condition. It's very hard to find patients that do not present urticarial rash. I have a patient that have just very few skin manifestation, and start we have more the neurological manifestation, the bossing, and the persistent inflammation with very few skin rash. That was mainly for the appearance and the persistent inflammation. I suspected an NLRP3 mutant disease, and I was able to make the diagnosis when he was 3 years old. But however, usually a severe synca patient starts very early. Sometimes you can have it very early also, patient like the case of Nicolò with a Michael Wells, less severe. So of course you have to wait. Unfortunately, the neurological involvement, as you have seen with Anna, is very early, also in synca. So if you have a combination of urticaria rash and a neurological involvement, you make the magnetic resonance and you find the meningitis, or you make the puncture and you find a sign of inflammation in the central liquid fluid, you have to suspect that this rash is pertinent to a very severe condition, synca. If you do not have neurological involvement and everything is just skin rash and urticaria rash, even if the child is so young, you have to think maybe this could be a less severe disease, a Michael-Wells disease. I hope I replied to your question.
So thank you, sir. Another question: how significant is somatic mosaicism in NLRP3 in clinical practice?
Yes, it's very significant, especially in patients with synca NOMID. I think that it's very important to screen for a gene. Or nowadays, with the new technique, usually making the panel according to how deep can go the panel in the identification, the search of the single gene, they can find out directly the mosaicism even in the first screening. But in the past, when there was the classical Sanger sequencing, I think that most of the patients were missed in terms of especially those that have very, very low frequency of this variant, and just with special technology, we were able to identify. However, is rather important because in the first year of observation of this syndrome, after the identification, we understood that almost 30% of the patients were with somatic mosaicism, with Chinka phenotype. That is a lot, so it's rather relevant.
Thank you, sir. Is SAA specific for autoinflammatory syndromes? That's another question from Shankar, sir.
Sorry, I didn't get your question.
Is SAA specific for autoinflammatory syndromes?
Serum amyloid A.
Yeah.
No, it's not specific at all. It's like CRP, as you know. However, you know very well that it's very important to mainly follow the patient because is much more able to identify a subclinical inflammation, more sensitive rather than normal CRP. Of course, maybe high sensitivity CRP is also very able, very sensitive, but serum amyloid A is rather easy to do. Not all the lab have it, but if the lab can do, it's not that difficult, and can give you this kind of subliminal inflammation that can help you a lot, especially in tuning the treatment in autoinflammatory disease. Because if you have a normal clinical normal clinical manifestation, no more fever, no more rash, and so on, but you still have some sign of inflammation, of course, you can increase the dose, trying to reduce the subclinical inflammation that in Synca and even in macro wells is an important thing to avoid, because we can assume if we found some inflammation in the blood, some inflammation can be also in the inner ear, and that is the reason why we have to really down modulate a lot with the treatment.
Thank you, sir. Another question, sir. Any role for mode in IL-1 mediated disorders?
Sorry, I didn't get.
Any role for mode in IL-1 mediated disorders? IGURA mode.
I didn't get the first part of the question. I understood the IL-1 mediated disease, but sorry, I didn't get the first part.
IL-1 mediated disorders. mode in IL-1 mediated disorders. Was asked by Suma Balan, madam.
Sorry, I really don't understand what you are saying. I'm sorry.
Okay, sir, sorry. Another last question, sir. Any experience in cochlear implant?
Yeah. Yes, we have some experience. We had an experience with Anna, I showed. Recently, she had a cochlear implant with a very good result. We discussed a lot this with the family and also with the colleague in NIH, with Raffaella Goldman-Maschi. They have, I think, 2 patients. There are a few patients in the world that has been that make a cochlear implant. And so far, I have to say that the outcome for Anna was very, very good. You have to do that in the proper way, with the proper timing. But I'm rather satisfied so far of the results.
Okay, thank you, sir. That's all for questions. So Ajit Kumar, sir.
So that mode that is used in rheumatoid arthritis, that was the question, whether it was used in.
Okay, I do not have any experience of that. My question for you: do you have anti-IL-1 blockers?
We don't have anakin right here.
So that is very important, of course.
And I think Dr. Geeta is here. Geeta P. Geeta P.
Geeta.
Hello, sir.
Yeah, Dr. Ajay.
Hello?
Sir.
We don't
Geeta,
have
madam.
Geeta. Okay. So that was a very nice talk, sir. Very informative talk on CAPS, Muckle-Wells, and NOMID. I think most of them are autosomal dominant, isn't it, sir?
Yeah, most of them are autosomical dominant, but as you know, as I told you, in Synca phenotype, we have de novo mutation.
Synca, you may have known. Okay.
Yeah, so there is no family history for that.
Okay.
Because, so that is the problem. Sometimes the family history is not helpful in the identification, more the clinical phenotype. The problem with this patient, I think that is very, very, let's say, very, very sad, because I would say that is unfortunately, I have to say that is very frustrating treating this patient without anti-1 blocker, because the story of this patient before 2005, I've seen a lot of these patients that has been born before this date, and was really very sad to say that very few drugs were helping them. No immunosuppressant, no other biologic anti-TNF, no, let's say, other drug. I'm reading here, of course, for example, using thalidomide and other drug. I don't know very well the drug before was mentioned. I try to come back. That is iguratimod. I'm sorry, I'm not aware, but essentially this patient can respond in a way to steroid, but became steroid dependent, and at a certain point is not possible anymore to. So I think that the only possibility is to struggle a lot to have an anakinra in India, or if possible some other drug, a biosimilar that can have the same mechanism. If you have problem in providing the drug, please call me, and maybe there will be some possibility maybe to use some inhibitors of NLRP3. So it's really sad to know that in our world there are patients that can be cured with in a very efficient way, and the only way to cure them, unfortunately, is using I1 blocker, because you understood the mechanism.
Yeah. We have Dr. C.K. Sasidhan, sir, our former HOD. Sir, can you give me your opinion? Can you,
I just want to make a comment. It's an excellent talk, a learning mode for me, and we certainly look into clinical problems in the years to come, I will say. We have come across these symptoms. One situation we come across is infantile eczema, atopic dermatitis, which may be for the autoinflammatory syndrome which I just described. Most of them coming with this type of urticarial rash, fever, they're treated with antibiotics and some emollients in the skin, they get better, but some do come back. So this is a very nice session for me. When such patient comes, we will certainly look into these autoinflammatory syndromes. In some of them, I think we probably be missing them for long. Thank you, Professor Marco, for an excellent.
It was my great pleasure. Is the real aim of the topic to discuss and to make aware the colleague of this rare, ultra rare disease. But however, indeed, when you see a patient with a strange urticarial rash, with fever and inflammation, that do not respond, not itching, do not respond to antihistaminics, you have to think about.
Thank you.
Thank you. We have Dr. Vinod Skaria from CSR IGAP. Vinod, any comments, any questions, Vinod?
No, I don't have any questions, but thank you, Dr. Gatona, for the fantastic talk.
Thank you very much indeed for inviting me.
Dr. Geeta Govindraj is our professor who is dealing with primary immunodeficiencies as well as autoinflammatory syndromes in Calicut Medical College. She's a what do you call lead here. And Geeta, can you just give your have something to say? Geeta, can you unmute? Geeta MG. Can you unmute? And you're muted.
Madam, please unmute.
Yeah. Is it okay now?
Yeah.
So, Professor Gatorno, thank you so much for that real eye-opener of a talk, because autoinflammatory syndromes are something that we are just starting to diagnose now that we are suspecting these. And actually, the aim of this series is to enable pediatricians to start suspecting and diagnosing these syndromes more often and helping these patients. As has been alluded to before, we do not have any IL-1 blockers in India to use in our patients. And so that is one drawback. So probably when we have data, that would possibly enable us to get access to these wonderful drugs that you are using over there.
Yeah.
I would like to call on Dr. Kishore if he's here. Dr. Kishore, please. Are you there?
Madam, not there, madam.
Not there. Okay, right.
Dr. Mohandas. Mohandas is president of Indian Academy of Pediatrics, Calicut branch, and he is professor of pediatrics in our department too. Mohandas.
Hello. Sir, it was a very nice talk, and we have seen few such cases in our institution also. And this series of talks on these autoinflammatory syndromes which we had for the last few weeks will definitely improve our capacity to diagnose and treat such conditions. And we are greatly benefited out of these lectures.
Yeah, I'm pretty sure because we are very, very, very skilled doctors, very, very able to recognize these conditions. So I hope also, and of course, I'm more than happy to help you whenever you want to make your diagnosis and then the management of this patient, including the patient in the registry. More than happy to help, of course, because this is, of course, the aim also not only of our institute but also the society. That is an international society that provide help for patients wherever they are. So we have to push a lot as a society to give the chance to all the patients in the world to receive a proper diagnosis and the treatment. This is our aim and our goal, what we have to do. So whatever you think could be useful for you, ask. Don't worry.
We can be part of some study, the project that you have mentioned. No, we can be part of the project and.
Excellent. Yes.
Yeah, we can, and I think Dr. Geeta will take it up. And Vinod Skara, I think it's high time that we should have Anakinra in our country.
Yeah, of course. We should actually tell the government that it needs to be approved and made available.
Yeah, because a lot of conditions it will be useful.
Right.
Jake, anyone to give the comments? Any other questions?
Hello.
No, sir. I think. Yeah.
Ajit, hello. Hello.
Dr. Suma,
yes.
Dr. Suma.
Yes, madam.
Hi. Hi, Marco. This is Dr. Suma from Kochi. I've been corresponding with you recently.
Hi, Suma.
About,
yes.
That child. Yeah. It is an issue with the IL-1 inhibitors, which is why I brought up this question about iguratumab. It's a Japanese drug, essentially, which they have trialed in RA, and it's actually quite helpful in those patients. But its main mode of action is through the NF-kappa B.
I see.
And it actually seems to be working on the inflammasome.
Okay.
So it was a query, really, if anyone has done any work from repurposing this drug in this format, That was the question.
No, I think
we've tried, we have a few patients with both, mutation proven caps as well as suspected. And there are the milder ones are actually doing pretty well with thalidomide or lenalidomide with no lasting issues at all.
Yeah.
But there are those who have, more severe problems, and it's very sad when we're not able to get them anakinra. I mean, I have actually written to the government with no avail so far, unfortunately. But the thing is, we are desperately on the hunt for other possibilities. We've tried JAK inhibitors as well, out of desperation, and they haven't helped. baricitinib hasn't helped.
Yeah.
So
it's so important what you say, because I think that the drug the possibility to analyze other drug could be very interesting, like the example that I show you for the sulfiram, that I don't think is a very expensive drug, but if you have the possibility to prove that a given drug is able to, in a way, compete, in this case is the formation of the pore of gasvermin for the pyroptosis. Of course, it will be very...
Yeah.
And what we can do, if you have suspicion of a drug that is not expensive, what we can provide using our tool, even using our mice model, to this drug, the drug that you think can be useful, have some impact, for example, in modulating the secretion of IL-1 by the monocytes, like I show you for the NLRP3 inhibitors.
Yeah.
And also it can provide some help in the mice model. So I think that we can help you also. I have to say that we provide in some grants with our friends that have this kind of technicalities from drug repository. But so far we were not able to have funding for that. That is a pity, maybe because the funding agency know that we have anti-L1, very expensive, and they don't want to make any effort on drug. But for this issue, especially for your countries, will be very important to have other possibility.
Because on your advice, I'm giving IL-1 right now to a child from Maldives whose government supports her therapy, and marvelous. The effect is marvelous, but it's very sad when we don't have it to offer to our own patients.
I don't understand that is more because, for example, do you have anti-I6?
Yes, we have anti-IL-6 both for intravenous and subcutaneous. Yeah.
It's not a matter of cost, because anti-I1 is absolutely the same cost of anti-I6 treatment. So the problem
is the lack of, they don't see a market for anti-IL-1.
That is the problem that I struggle a lot with the company, because it's more a problem of the company. And that is silly, because if you think to 1 billion person and the possibility to have much more patients with CAPS than in Italy, of course, in India. So it's something that we have to struggle a lot with the company.
Thank you.
My pleasure. Of course, I'm more than happy to try to help as a society, as an expert, and so on, because it's so important.
We do. Yeah, that's fine.
Yeah, Soma, continue.
No. I was just asking one more thing, because each pre-filled syringe comes up as 100 milligram. What have you had any experiences with splitting the syringe over a couple of days? Because that's what we do for when a few times we've got it in a severe HLH or that kind of scenario. We've done that. We split the dose over a couple of days.
So splitting a dose one day and then the other day.
Yeah.
You can do,
because
if you say there is no proof that after 24 hours the drug in the fridge is still the same function. Otherwise, I understand that if you do not have any other possibility, you can try, but theoretically you should not.
Okay.
From the let's say point of view, regulatory point of view, of course.
Yes. Thank you.
My pleasure.
Thank you, Dr. Suma, and Dr. Ajay for the vote of thanks.
Hello, sir. Can you hear now?
Yeah.
Yes, sir. Firstly, I would like to thank Dr. Marco for the excellent discussion sir has done. on systemic autoinflammatory, and Dr. Ajit Kumar sir for coordinating the session. And finally, I would like to thank Dr. Vinod and Dr. Geeta, who has been behind this pediatric immunology seminars for the last 1 month. There's been a it has been a it's a webinar of informations. So, and this is the first time I think we are having this type of immunology series in the whole of India. Thank you, madam, and thank you, Dr. Vinod Kumar sir, and also Dr. Mohandas sir, our IAP president, for coordinating the sessions. Thank you, sir. And also all the participants, Dr. Suma madam, Dr. C.K. Shashisan sir, and Dr. Sabik, who coordinated the chat sessions. Thank you, everyone.
So thank you, sir. Thank you very much. And it was really a real pleasure interacting with you.
Thank you, Dr. Marco. Thank you.
Thank you very much. So next time in India.
Yeah, definitely. Yeah.
Okay.
Thank you, everyone. Good night.
Bye-bye. Thank you very much. Take care.